is Peter Blumenthal, your steward and current president. Welcome to tonight's Policy and Strategy panel. These meetings are now in the hands of our capable incoming president, Nicole Hendry-Dinyal, and I give her the podium.
Welcome, everybody. We're excited to have you all here. As we all know, that AI is it's where it's at. And I think in every industry, they're all trying to figure out how do they uptake it responsibly. I think nowhere other than in healthcare, where we have so much regulation and so much at risk if it's not done properly. So we really are excited to present this to you. We have wonderful speakers and a breadth of expertise. And I'm excited for this. You know, I tell everyone I had a virtual scribe, meaning of a live person. And because we're going to try to transition to AI, there's definitely monies that can be saved there. So the organization has decided to do that, which makes complete sense. We haven't quite adopted the AI part. So I introduce it as it's me-I right now. And I can't wait till we get to AI. So with that, I'd like to introduce our first set. What we'd like to do is, with AI, we know there's wonderful promises that we can do, but there's also some cautions. And so promises and perils is our objective tonight. We're going to have our speakers present. It's short, and I apologize because there's so much that can be said. But then it hopefully will allow us to do a panel discussion. So we'll do a Q&A at the end. And so feel free to submit questions to the Q&A. And then when we get to that part, that's when we'll probably do the question and answer. So if you have a burning question, you're not alone. Go ahead and put it in the Q&A, and we'll get to that when we get to the panel. Okay? And so with that, I'm going to introduce our first speaker. It's Dr. Kennedy Ganti, and he's our former MSNJ president. He's the Regional Vice President of Health Informatics at RWJ Barnabas Health. He's a board-certified family physician and clinical informatician. He's the founding chair of New Jersey's Health Information Technology Commission, and he's the chair of One Health New Jersey. It's the state's only physician health information exchange. Again, past president of the Medical Society of New Jersey and fellow of the AAFP. He's Seton Hall's Healthcare Executive Leadership Academy. And with that, I will introduce Dr. Ganti. We have the speakers after him that will speak about promises. Will be Dr. Parsa Mahaji. He's the founder of Cognome, professor of systems and computational biology at Albert Einstein College of Medicine, the director of the Center of Health Data Innovations, the chief technical officer at New York Clinical Data Research Network. He's the creator of Cognome, designed to unify fragmented healthcare analytics. And a fun fact, born in Iran, he introduced the country's first internet connection and built its first EHR, and it is still in use today. So wonderful to have you here. After Dr. Mahaji, we'll have Vikas Khosla. He is the strategic growth advisor from Cognome, health tech entrepreneur and advisor with over 20 years of leading digital health in cybersecurity ventures. He works with health systems and startups to scale innovations and market impact. His also fun fact is a passionate home chef and drummer. Lives in New Jersey near Philadelphia with his wife and 2 children. So welcome. I'll give the floor to Dr. Ganti.
Thank you so much for that warm and detailed introduction, Nicole. And it's an honor and a privilege to present to you all. And it's great to see we have a nice, good-sized crowd, but we can all be cozy and a bit intimate. So I'd like to express my gratitude to all of our panelists today, starting off with the promise of augmented intelligence. And I use the word augmented intelligence intentionally because as a member of the Medical Society of New Jersey and card-carrying member of the American Medical Association, it is the preferred term that we use in organized medicine called augmented intelligence. And it is really at the center of really what the big AI debates, including its different technologies and governance, and a leading group called CHAI is really advocating for what the AMA is also supporting, which is keeping a person in the loop. And in context of what we're going to talk about tonight, a physician in the loop, in the middle of care. So with that, I would like to then move on to talk about to you tonight the AI that you can see. So I'm going to start a deck here and then start sharing. Okay, so I'm going to get the desktop one, share that, and then start the presentation. And you should see that, and we will now start our presentation. So the AI that you can see, or the augmented intelligence you can see, really, and in organized medicine, what we talk about are some of the contents of what we talk about AI. So augmented intelligence, the patient-physician relationship, right? That's sacrosanct. It's the center of everything we do. The virtual scribe, the more popularized term for the ambient AI, clinical intelligence, and all the various synonyms. And then the art of the reply, or augmented response technology, which is now finding its way into patient portals. And then if we have time, probably found in translation, we're going to probably defer on that tonight. So we're going to talk about two major areas. But moving on, we're going to talk about augmented intelligence, keeping a physician in the loop, and what technologies are there that really surround it, and what does this mean? So there's a lot of hype in medicine on AI, just to show you.
Welcome to the future of medicine, a world enhanced by augmented intelligence. This video will explore the role of AI in enhancing medical practices and patient care. Let's look at how augmented intelligence is transforming diagnostics and treatment. With AI, physicians can access data like never before, improving outcomes. The incorporation of AI aids in early detection, saving lives. As we advance, human and AI collaboration will redefine healthcare delivery. Join us as we embrace the evolution with augmented intelligence.
Very Silicon Valley-esque, right?
Welcome to the...
So there's a lot of hype, but many of you saw this wonderful, polished presentation, right? The experts on this panel tonight saw all the hallucinations, all the little things that were off, that were just like, what? So for those of us, I hopefully at the end of our session tonight, you will be more aware of what's out there and less bamboozled. So moving on. So we want to focus on tools that augment the physician-patient relationship, right? Otherwise, why do we want to use it, especially as physicians in organized medicine? The virtual scribe, the ambient AI, the ambient clinical intelligence. These are the synonyms for that tool that you have on your smartphone and use with the patient. You record the conversation and leveraging generative AI somewhere in the background with some model, with some recording feature. It then transcribes, and then if it does a good job, it automatically formats into your note and may even format different spawns, if you will, into, say, the after visit summary or what patient takes home or to a portal. So that's what we're looking at today, and it's really on fire. It's really a very, very hot, very fast-growing area with a lot of competitors, big and small. And when we talk about ambient AI, we have to talk about really what's the core feature here, and it's really, speech to text. Accurate spoken transcription, real-time voice recognition, multilingual support and translation, which is now starting to come to the fore, especially with Spanish. Dictation software integration. So really capturing a conversation and formatting in a note to where you pretty much can go hands-free for part of the encounter with your patients. And I've been very fortunate to, as some of my colleagues on the panel will tell you that they've used, but it is not without error. It is not without risk. It is not without peril. But it does blaze forward a opportunity for us to grab the relationship with our patients again. And that's where the promise of this technology is. So again, in our final point, enhanced patient engagement, just having that eye to eye, having that heart to heart. And again, we should already be doing that, but it is, with, all the converging competitive needs of documentation, value-based care, and depending on your specialty, quality metrics, there's a lot to be asked of. So having a technology that sort of helps us back off is very, very tempting. So speech triggering EHR commands, in addition to speech to text, voice controlled, streamlined data entry. And it's been shown that just having, those kind of shortcuts also can lessen clinician workload and cognitive burden. And then when you have some automation going on without constant typing, that lends itself to better communication with our patients, being able to, get a few points in. And then also having, accurate documentation, with live updates to charts. And these are all precursors to these needs that we have for documentation. We need to have clear communication, good record keeping, and, data management, structured data, analytics, predictive modeling, cognitive computing. All these things are swirling around as part of what we do. What is ambient clinical intelligence? This so-called virtual scribe, has the effects of boosting physician workflow. Less documentation is needed. Word count is becoming an issue with EHRs. Enhances our dialogue. Hey, mom, no hands. Look. And then finally, insights, being data rich, being data, being plugged in, having different models, being able to look at different parts of the patient's chart and integrating information is very, very powerful. And, lends itself almost to intelligence, but it's not quite there yet. And then what's the other technology that's, going to, play a role with the patient-physician relationship? It's the technology that you see when the patient is not there, and that's through the patient portal. So, when we look at patient portals, it's been a new tool, but has, added to the physician workload. But it allows for more timely communication, urgent communication, and then with a guidance, in explaining tests and imaging, as we often many do, it eases patients' anxiety and enhances engagement. And then patient portals, have evolved over the last decade, starting from, in the last decade, from meaningful use, and then the Blue Button Initiative through CMS and the VA, and then this movement towards continually sharing more patients' information with the patient. Forsooth, and that's been the revolution here. And then open notes, and then the APIs, and this is allowing for growth of an ecosystem. So API stands for application interface. So these are connectors to different types of applications, cloud environments, different use cases, and different technologies. And so Smart on Fire, the Fast Healthcare Interoperability Standard, Project Argonaut, these things created all of these different applications of where information is. So that being said, ONC doubles down with certification and the 21st Century Cures Act to really make, patient portals important. And then you have new message types, new physician workflows, and new demands. So with that, you have these great communication methods and enhanced interaction designs, but it's still a load. So then when you have automated response technology, it's really in that portal an automated message based on, this response that is your virtual answer. So for example, says, Doc, I need a refill of my metoprolol. And then the ART generates, oh, I have your refill of metoprolol ready. Please confirm your pharmacy. So that tees up for you, and then you can go ahead and add to it and send it. So yes, it does decrease the load, but just like with any of these technologies, as you may have started to see, there are hallucinations. And I'm going to defer to that in our second half of our talk about the perils of augmented intelligence. So as we move forward, I would like to thank you very, very much for your attention on looking at the patient-physician facing technologies, such as the virtual scribe and such as ART. Now, what I would like to do is yield to Dr. Parsa Maharji to talk about the AI you don't see. A lot of the things that Cognome and his colleagues do that protect healthcare and automate healthcare in the background. Dr. Maharji.
Thank you very much, Dr. Gunty. This was a very good introduction to how AI in the forefront transforms and may impact care. What I'm going to talk about is to really look into how machine learning works and how it is embedded across the spectrum of the health system operations and the different use cases in different areas that you may not recognize it directly, but it is part of the workflow now, and it is really scaling operations in both clinical, operational, research, training, and how these data-driven approaches work. I'm assuming that you can see my screen. Before I go into some of the details, I just want to establish how machine learning algorithms are trained and where some of those problems that you were mentioning in terms of hallucinations or bias may come from. Machine learning algorithms essentially learn from examples. If you want to create an algorithm that can recognize airplanes and simulate flight, you show them examples of all kinds of airplanes that fly. You test them and they learn by try and error. As they fail, they retry, they adopt different approaches, and they get better and better. And sometimes they surpass human beings in those things. Humans are not directly involved in machine learning in training. Expert opinion and domain expertise comes to the picture on curation of the examples, preparation of data that we use for training, or on validation of the results. Training are essentially done by machines. And this gives you an idea about where some of these bugs and biases may come from. If the data and examples that we are using are biased, are incomplete, are inconclusive, AI will make things up, will make errors, will have bias. If our validation of results are not accurate, AI will learn to do the wrong things confidently because it was validated in the past by human beings. So this process is essentially what drives all of the algorithms that we call them deep learning, generative AI. It is essentially this. And the generative AI, the Geminis of the world and OpenAIs of the world are essentially the same thing, but in much larger scale. ChatGPT is essentially trained on entirety of the internet's content in a much deeper, much more complex learning algorithm that results in a multi-talented algorithm that in this case can play guitar as well as answer the existential questions about physics and life. But it is essentially the same thing. Bad data, wrong validation, a lot of potential for bias may come. And that middle bucket of deep neural networks is where the complexity lies, where some of the problems that we see may emerge from. And this is an old slide from 2-3 years ago, but essentially it shows that these really large, complex learning models have started meeting or surpassing human capacity in almost every category of a complex cognitive task that normally was preserved for human beings, from visual to cognitive functionalities, speech, both generation and recognition, mathematical analysis. They now have either matched or surpassed human beings. But essentially, the point I was going to make is that they're all black boxes. This image actually is showing the best deep learning algorithm that we know. Dogs that sniff bombs or explosives or drugs in airport are an example of deep learning algorithm trained They do a really good job, but they cannot explain how they are finding things. You can't take a dog to the court and use the explanations of a dog in court, but they're very useful. We use them. And that's essential problem of these really useful tools that are in essence not explainable. We do go in a long miles to build better and more sophisticated algorithms, but they're still black box. So with that said, with that intro, I'm going to look into promises on adopting AI and incorporating that into the workflows in healthcare system and how we've been able to really start impacting healthcare. The first area, probably the most impactful area that AI may transform healthcare is in really getting it right from a learning health system perspective. We know that at least presently the traditional healthcare comes to contact with patients, or patients come to contact with us when they have a medical problem. They talk about their clinical condition, their symptoms, their clinical experiences, and that has been traditionally what drove care. But we know that there are a lot of influencers of that. Patients' genetic is important, their behaviors, the environment and conditions they live in, the kind of community and society that their community resides in, the regulatory conditions, just access to vaccination, for example, or specific drugs, the kind of healthcare system that is available to them, the kind of doctors and their training, the kind of medications that are available to that patient, all of the other social economic determinants, the newest knowledge created by research, what the latest publications were about these things, and access to all of this, availability of all of this. These are all gears of a really complex gearbox that so far, although we know them, we didn't really have a good way of putting them together, understanding where the connections are, how these influencers work with each other, and how they drive patients' experience clinically and throughout their life, and how a healthcare system can learn from every single patient that they see. So that patient-centric approach to precision medicine, personalized medicine, using all of these data domains and leveraging that for improving the healthcare itself as we drive precision medicine is the most important area of clinical applications of AI that we think AI will make the most important transformative impact. But beyond this, and these are projects that we have now started really with the tools, with the data, and with the computational systems that we now have available to us, start to build really AI-enabled learning health systems, AI-enabled patient-centered and patient and personalized medicine approaches. But if you look into each one of these boxes, there are also a lot of applications for AI. For example, just in the clinical areas, there are multiple applications for creating clinical decision support systems, prediction and projection algorithms. Dr. Ganti talked about the potential use of AI for augmentation of interactions of doctors with patients, or documentation of care and so forth, that they are relevant. For example, these are actual use cases that we've been building in Montefiore and have deployed system-wide algorithms that could recognize sepsis earlier than physicians, enough for them to make an impact hours in advance, and then look over the shoulders of all of the team members that are taking care of sepsis patients to make sure that they're following the guidelines, they're following the best practices, and so forth. We've built algorithms to identify patients that would have metastatic cancer to the spinal cord months in advance of these conditions becoming symptomatic. Algorithms that would identify patients that would require ICU hospitalization, mechanical ventilation for more than 72 hours, which is the definition of respiratory failure. Detecting clinical deterioration of the patients, again, hours in advance to optimize end-of-life planning and so forth in clinical setting. They are all embedded in the clinical pathways and workflows, and they come through the EMR systems and try to provide a high quality care system-wide. On operational settings, again, there are a lot of applications for use of AI by embedding them into workflows, from optimization to pattern recognition, signal detection, and creating efficiencies that may not be data-driven efficiencies in logistics, in care planning, assigning resources, and so forth. Examples of those were projection algorithms that we built during COVID to drive management of resources at Montefiore that were essentially projecting the census of every single facility in the hospital, as well as the overall health system in terms of admissions 3 weeks to 2 weeks in advance. So we knew day by day how many patients will be in the hospital and how many patients will come through as new admissions. And we were able to manage the operational aspects of catering for those patients. We built algorithms that would predict cancellations of day surgeries that are very expensive, and they also reduce the outcomes of patients. When patients don't show up for a planned surgery, it's a lot of cost for hospital, and patients start deteriorating, showing that there was a significant reduction of these cancellations by way of creating follow-ups to coordinate for identifying reasons why patients cannot come to their appointment, and dealing with those in advance. If it is insurance policy, if it is commute, if it is care optimization, medical optimization before, do them so by the time that the time comes for operation, patient is ready. And so forth. Because Dr. Ganti did a fantastic job in other more visible aspect of this, I will not talk about all of the summarization and language understanding and communication frameworks that were deployed as part of this. Research is a big area of AI application, from discoveries, hypothesis generation, administering clinical trials, from screening patients, recruiting patients, following up the patients, decentralization of the clinical trials, scaling clinical trials to pragmatic and more dynamic clinical trials across the health systems, and so forth. Examples of those applications were, as I mentioned, algorithms that can match patients to really complex clinical trials based on multimodal data, based on all of the structured data in EMR, all of the notes from pathology, radiology, and procedure notes, as well as biomolecular testing information, and explain why patients would be eligible to the physicians and to the patients themselves. Why would this be a good clinical trial, beneficial trial for you? Why or if the patients that we're hoping that they're gonna benefit from a new investigational therapeutics, why they're not eligible. This explanation to the care teams, to the research team, as well as patient, is really important in participatory, inclusive, and equitable access to research that now we are able to provide for patients using these advanced analytics. And there are several large-scale national applications of AI in areas related to mental health, youth suicide, stigma, detection of stigma throughout the care delivery process that teenagers may go through, or being able to identify patients with intellectual and developmental disorders early on, so we can put them in more optimized care paths using some of these algorithms. And finally, training, just creating a workforce that is more data-driven, that are familiar with these tools and able to basically use data, use analytics in their own medical training and in their own career advancement. An example of these kinds of training tools are matching residents to programs that are actually aligned with their skills, with their interests and their performance, rather than doing a chance application to several areas, starting in the first year of the medical school, second year of medical school, identifying which student would be a good surgeon, which would be a good emergency medicine physician, and try to create a more adaptive curriculum for those and make sure that everyone gets a chance to improve their learning, rather than providing an one size fits all approach to medical training. So I try to be to cover all of the areas, but there are so many other things that AI could do. I would like to just end with saying that all of these are nice, very good applications, but that's a problem of explainability, potential bias, and trustworthiness issues are present with all of these applications. We know for a fact that for someone with bad intent, it is very easy to manipulate manipulate these algorithms to produce wrong results. This example that I'm showing you shows that by adding just a little bit of a noise that is unrecognizable, you can basically force an algorithm to recognize an ostrich when there is a school bus. And this can be done to commit fraud, to harm patients, or to influence decision-making of a healthcare system to benefit certain processes. We know Dr. Ganti mentioned that these algorithms hallucinate because of the incompleteness of the data that they have been trained on, or the complexity of the task that is not available, or these algorithms are not trained to deal with. Hallucination has many, many reasons, but is almost impossible to reduce. It's the fact of using these algorithms, and we have to find ways to recognize them, identify them, and mitigate them, rather than trying to eliminate them. Discrimination, bias, fairness issues that will come by using these algorithms is there too, as well as ethical AI. You can do fantastic things with AI, and the question will be, should we? For example, should we use AI to predict patients' susceptibility to certain genetic or familial disorders years in advance, and let the patients know when they can't do anything about it? If we can't help, should we do it? These are ethical, philosophical questions that we should think about them before we jump into applying these things. So some care is going to be required in applications of these things.
Dr. Marhaji, with that said, I'm thinking that was a perfect segue you know,
Yes,
to Vikas, and because he's going to talk now about ensuring safe and ethical AI.
exactly. Thank you very much for the
Thank
opportunity.
you.
Can everyone hear me? Okay, good. This went off mute. Let me find my slide deck so I can share that. Okay, can you see the deck?
Yes.
There we go. Yep,
Full screen? All
Yep.
good?
we're all good.
Well, you know, and Dr. Dindal, as you said, you know, Dr. Miraji and actually Dr. Yanti teed me up perfectly. I always feel like after listening to the two of them, I've sat through some sort of a master class. I am not a physician, so I always learn a lot of things. But my area really is around AI governance. So I'm going to get into some of the more practical aspects and sort of what's happening in the state of AI governance today around the industry. And I'll touch on a lot of the topics that both doctors touched on here. I have to flash this confidentiality statement. And so we'll kind of go through the role of unified governance. We'll talk about some best practice frameworks from the NIH as well as NIST. We'll also dive into what committees look like, what typical AI governance committees, what functions they perform, and then sort of peeling back the layers of what the governance, what are we governing? What does that tech stack of AI and machine learning look like? And then I'll give you some show and tell and actually show you some of the innovations that Dr. Miraji and his team at Cognome, our team at Cognome, have put together with some of their visualization capabilities around explainability, which is so key. And at the end of this deck, I think it's going to be distributed. If you'd like to learn a little bit more about Cognome, there's some information there. So with that, I already got my introduction, so I'm not going to do any further introductions other than to say I'm a healthcare technology lifer. My passion is innovating healthcare to transform the care delivery system. This is what I do, why I do what I do, and wake up every day. So talking a little bit about unified governance and what are some of the key principles, excuse me, what are some of the key principles about for unified governance? So, you know, one of the points I want to get across that it is a sum of everything. This is not one specific type of thing that creates a good, robust AI governance framework for an organization. It's a combination of all of the things that you see throughout this slide, but certainly people, process, policies, culture, and then the ability to really govern and be accountable for what we're doing and how we're doing it. It requires continuous oversight, as you'll see in one of my slides as I talk about the tech stack. It isn't when you are really diving into deploying AI, using AI, you really can't ever pause and not think about what is happening as those models are running, because so many of them run in the blind, you know, in the background. And I'm sure for those folks that either are working on it, I'm sure generally everybody would agree that we need to be making sure that we're meeting industry leading standards, which is why I'm going to show some of the frameworks that I'm going to show here, and that we are providing information that is transparent, understandable, and obviously ethical. But good governance isn't about stifling innovation. It's really meant to empower collaboration around AI. It's meant to empower people to innovate. And I believe we're already seeing, you know, sort of examples of this. So by putting all of these things together is really how we create long-lasting value and empower people to really leverage AI. So again, governance isn't about stopping something, it's about enabling something. And quite honestly, if you're not working on AI governance at this point, I mean, it's hard to even imagine an organization that would say that they're not either working on it or have done it. Montefiore Health under Dr. Miraji took 3 years to implement their AI governance program. They have a very robust program. It does take time, but you have to be working on it. A year, 2 years ago, you could have probably gotten away with not working on it. At this point, obviously, we need to be moving forward and making progress. So who are we really serving when we think about a really robust AI governance program? I kind of put it into these three buckets of the primary, consumers and users of AI for whom we have to build trust and ensure that we're operating and managing these tools ethically. So clinicians and patients, especially clinicians, and we'll focus a lot on the clinician viewpoint here, but they need that explainability. They need to be able to trust these solutions. One of the biggest challenges that we're having industry-wide right now is adoption by clinicians because they do not trust these models, and especially things that are predicting things but are opaque, or black box models, as Parser referred to them. And in fact, there was a study recently that showed that an overwhelming majority of patients believed that the health systems and the providers that they were going to that were leveraging AI already had full AI governance in place. And as we know, that is not the case. So the perception and the reality kind of are at a mismatch. So we're kind of on a race here, if you will, to meet expectations. Now, the data scientists and the informatics that are working on these models, that are really responsible for the analytics, the performance, they need visibility into these models as well. So governance gives them that visibility into what is happening within the organization with not only their, but other solutions. And of course, our technology leaders, our CIOs, our chief security officers are very concerned about compliance, but they're also very concerned about accountability and ownership because there's so much trepidation around what could go wrong, the perils, as we were talking about here. Accountability and ownership are really key. And right now, what we're seeing is a struggle between business units and C-suite leaders around who's going to be accountable and have ownership over these solutions, because so many of them are being brought in by the business units. And for those folks, obviously, they need the resources to make sure that they have the infrastructure, the capabilities, the resource, the budget wherewithal, and the human capital in order to maintain and produce these at a high performing level. So with that, let's dive into one of the best practices frameworks. And so I really leverage NIH. The majority of reference out there to good governance, you'll end up coming back to some NIH website or model or publication. And so they very early on, as you can tell from the style, the design of this graphic, very early on, many years ago, established their 4 pillars around AI governance. So fairness, trustworthiness, leading to transparency, and then that accountability component that I talked about earlier. These things really need to work together to ensure that trust and that adoption. They also published an ethical framework for artificial intelligence, and I think this speaks much more to our audience here today in thinking about how do we really adopt and then continue to monitor AI within our organizations. And Dr. Meraji says something that I really always have in the back of my mind, that this is not something new, what we're doing with AI governance. We've been doing this for a very, very long time. Clinicians and clinical leaders have been doing this for a very, very long time. What he says is treat AI as an intervention, similar to the way we would treat any other intervention. So we shouldn't be scared of this. There is a paradigm here that we can follow to incorporate this. So I put in reference links to all of these things. I won't dive into it's a lot here, but if you want to look at this further, this is again one of those core references for ethical uses of artificial intelligence. The other thing that they also have a paper on is clinical workflow integration. So they did a lot of studies, or studied a lot of studies, of how we can properly integrate. So again, going back to that treat AI as an intervention concept, and how do we get AI applications within clinical workflows and as part of our good governance, surrounded by the 4 pillars and the principles that you saw before. Another framework that you may not be familiar with, but your technology and your security and your compliance folks will be very aware of and are working actively on, is the NIST AI Risk Management Framework. So this really comes at it from a cybersecurity, privacy, compliance, HIPAA, all of those things wrapped in together into this 4-part framework that they've published, which is now, I think, on version 2, that ensures that our AI is explainable, that it has meaning, that it can be interpreted correctly, that the explanation is accurate, and that again comes with that transparency component, and that the AI is working within the realm for which it was designed. Parsa gave a lot of examples around hallucinations and how biases are so easily introduced, which sort of doubles down on this point of knowledge limits. So use it for the intended purpose, similar to interventions. So what are some of the key functions? So this is a very generalized thing. This will look different at a lot of different organizations. It'll look different. But I would say this is fundamentally the core of what an AI committee looks like when you start to establish governance. Education and awareness are key, right? So there's not most people don't know a lot about these things, and the awareness around what it is and how we use it and our standards for using it must be elevated. I would imagine most organizations have a strategy and a roadmap. The thing that I really focus on when I work with clients is around the use cases. I come at it almost always from a use case perspective. And then how do we prioritize these use cases? So what's most valuable to us? How do we vet it? And then how do we prioritize it? And where does it go into our roadmap so this can be a manageable process of implementation? I talked about privacy, security, and compliance. Clearly, those folks need to be plugged into this. We need standards not only for the development, deployment, implementation, and maintenance, but for the acquisition. This whole concept of shadow AI is just sort of an epidemic in the industry right now. I'm sure your CIOs and CISOs are talking about this. So standards for how we acquire it need to be thought about. So the beginning of the program is not when we look to deploy, but it's when we look to acquire. And then if you're an academic organization, IRB integration obviously is key there. A lot of people forget about marketing. If something bad happens, we need marketing and public relations to be plugged in so they can message properly out to the community, whether it's the physician community, whether it's the patient community at large, they need to be plugged into this too. And a lot of folks, because they are working so much on optimizing their data for use of AI, have sort of started to discover a lot of commercialization options. Cognome is one of those things. For the 15 years that Dr. Meraji has been building his incredible stack, which I would say is 5 or 10 years ahead of where the industry is at today, Cognome was formed as a spin out of multiple health systems that he was working with. And so commercialization options are there too. And people are starting to get into data commercialization as well. How am I doing on time? Do I need to start wrapping up? I've got a few more slides.
Yeah,
Okay.
thanks.
2 minutes? Okay.
Yeah.
So again, I want to give you a peek under the hood of this is more from a technologist perspective. What do we think about when we think about the AI governance tech stack, if you will? Starts with our data sources, starts with aligning to regulatory frameworks, the development, implementation, and then the maintenance of these models with our AI and MLOps teams, which then lead to the deployment of generative AI and machine learning models for predictive analytics. Well, on top of all of that has to be this continuous governance. And that's why really we're putting down the gold-plated piping here, really, as we think about operationalizing AI through continuous governance. I won't go too much into this. I think explainability was covered, and for sake of time, but obviously I think we understand these concepts, so I won't spend too much time there. But I did want to talk a little bit about explainability features. So what are people looking for when they think about explainability, when they think about responsible AI? They need to be able to manage their portfolio of models, the performance of their portfolio of models. They need to know when things are out of bounds, whether they are exhibiting bias, whether they're behaving responsibly. Are there hallucinations? Is the model drifting? And all models will drift. So if they're drifting, we need to be able to see how the drift is happening and to be able to correct those things. We talked about black box models. The Cognome has really developed, I think, a very innovative solution and platform to be able to look at what these black box models are doing and how they're performing, which is a big gap in the industry right now. And then, of course, especially for clinicians, making sure all of this is integrated within our EHRs, we get the right alerts at the right time. We have the ability to audit for traceability, and lineage tracking is really important too. So with that, I want to give you, and I'll close on this. This will take not even 30 seconds probably, but just some visualizations of what what a platform could look like that is able to now visualize AI governance for you and for its various stakeholders. So this is a screenshot of a dashboard that assesses a model, a generative AI model for all of the things that you see on the left, not only just hallucinations, but is PHI leaking? You know, is there potentially a prompt injection? Is it factual? Is there traceability in it? And the ability to give you a judgment on that using a judge and jury model as far as the LLM ensemble is concerned. Here's a machine learning model, a sepsis model that Parser referred to earlier. And this is what explainability looks like, right? So this is the tangible aspect of it. So now the clinician is able to see, or whoever's looking at it, data scientists looking at it, they can see when something gets flagged, why was it flagged, and what were the leading contributors. This will look different. This chart at the bottom will look different for different patients in terms of what contributed to the prediction of sepsis for this person. Similarly here, more ways to see, hey, is it factual? Are the actual inputs reflecting how we trained the model? Are there differences? Is there drift? Can we see that, and being able to visualize it is really, really important. And then some of the other aspects of fairness, bias, ethics we talked about, but also, you know, different ways to look at performance, ways to look at actuals versus predictions. That's really, really important. And then looking at this demographic data for bias and ethical responsibility of race, age, gender, ethnicity, and various other ways to look at slice and dice this data. So yeah, so those are some of the screenshots. I thank you for the time. Hopefully I didn't take too long, and you guys got some value out of the presentation.
Yeah, we can make it up with the panel. So thank you very much. I mean, some of it, when you think about everything that goes into AI, could just like literally go over our heads for some of it, but it's so intricate. And I think in the clinical setting, we just want to really be careful that we are doing it in an intelligent way. And so we thank you for showing us the promises. I'd like to present our next two speakers, and they will touch in on some of the perils. And so Dr. Jennifer Bryan is the immediate past president of the Mississippi Medical Association. She's a family physician at St. Dominic Medical, right? It's the
Hattiesburg Clinic now.
at the Hattiesburg Clinic, right? I was just going to say, I thought you were at Hattiesburg.
I am. That's
Thank you.
probably an old bio.
All right. So at the Hattiesburg Clinic, she's the first female chair of MSMA Board of Trustees. She's a current AMA delegate. She's the past president of the Massachusetts Medical Society Young Physicians section, and she's a leading physician voice in the state national media that occurred throughout the pandemic. She founded the Quiet Signal Technologies. It's an AI governance platform. And with that, I introduce Jennifer Bryan.
Thank you, guys. I'm very grateful to be here with you all to talk about something that I'm very passionate about. This came from my experience, 19 years at the bedside. Like many of you, I'm a family physician. I see patients every day. That's my real job, and a policy wonk on the side. I'm always just trying to make the field of medicine better, and stumbled into AI along the way. And really, as Kennedy said, it wasn't ready for prime time, and I saw a need. I saw the peril. I want to bring this back a second. I think we feel like in ways like AI is coming, or maybe this is brand new, but AI already lives inside of your electronic health record you've been using for years. It curates what we see in the exam room, almost like Netflix curates our watch list. It decides what order sets that we see sometimes, which diagnoses pop up as a likely, which codes you may see suggested. There's pattern matching AI inside of the electronic health record, and there has been for years, just like your movie recommendations are within Netflix. Only here, the cost of a bad recommendation isn't just a wasted evening. It could be a human life or a malpractice claim. Those suggestions that look so authoritative at times, many of them rest on weak logic. Many times they're unfounded, and there's hidden liability. For instance, if you've got a patient that takes a GLP-1, For weight loss, suddenly your chart may suggest that they have diabetes. I've seen in my own practice, I don't know how many times I send a patient for a lung cancer screening, a benign nodule is found. It's suggested to me, don't you think they have lung cancer? And when you run patients through your practice over and over, we have human error baked in. So those are tripwires for human error to come through where lung cancer quietly slips through and our name's on the claim. When the algorithm is wrong, that's where the policy mind kind of came forward. And those of you who are on this call, I would be willing to bet you're wired a lot like me. This is where the physician risk came to mind. Our names are on the claims. Who carries that liability? Generally, it's not the vendor. And a lot of times, the health system administrators have said, hey, these suggestions are great. We want you to get credit in your value-based system for the complexity of your patients. But those suggestions are not always accurate. So you make sure you check. But we know that you're burned out too, right? And so a lot of times everybody has done this with disclaimers. And it comes down to you who has seen a bunch of patients and you're tired. And we really don't need unhelpful suggestions that put you at more risk and liability. So it lands on you. There's extra revenue that comes from these things. But when the audit comes and the documentation doesn't support it, they turn to you and say, but you signed it. And some of that's expected. I mean, I don't want to act like everybody's going to jail over, one bad code. But as the years go by, if we don't learn how to govern this stuff, we can only claim our naivety for a while. We've got to get control of this problem that's been so eloquently explained before me. And this redistribution of risk, as I like to call it, AI is pushing this revenue upstream, the liability downstream, pushing it all straight onto our backs. We have got to figure it out. Nobody's going to figure it out for us. Physician leaders need to be at the table. The black box that we've been talking about and the need for provenance or evidence trails. The black box is a real problem, and there's proprietary reasons for that. Each of these vendors that have worked for years to set up why you should get Allscripts or Epic or Oracle Cerner or eClinicalWorks or whatever it is that you're using, they've got their reason that you should use their database and the reason that they are making these suggestions, but we can no longer accept because I said that this is the reason. If an AI generates a recommendation, we've got to be able to see where it came from. Did you get this suggestion from Reddit with 5% confidence, or did you get it from the American College of Cardiology guidelines from 2025? I need to know, was it a hallucination? Did you drift like we talked about? I need to know where this came from. Are you 100% confident? Where did you get it? We need confidence scores. We need source tracing. You would never prescribe a medication without knowing the dose and the indication. And so why would we accept advice from a model without knowing how certain it was or what the evidence was? The other thing, not only those crazy suggestions that come through that say, don't you think this patient has lung cancer? And by the way, lots of cancer suggestions that patients don't have. It keeps reminding you. So there's not just one tripwire, it comes up the next time. And definitely in January, when we're all required, everything is new again to address these conditions, it reminds you over and over again. Governance systems can come in and suppress those things for good. So you don't keep getting this bad logic over and over again, because each time is a risk. And with patient portals, you can scare them to death, thinking you forgot to tell them that they had end-stage renal disease or all these bad diagnoses. It's happening. And by the time it touches the HIE, which connects all of us across the country, our records are quickly really becoming a problem. The AMA says 88% of health systems across the country right now do not have proper governance, 88%. And we've got to get a handle on it. With AI, another important thing from my perspective is that we have credential-based invocation. AI can be a great puppeteer in the hands of anybody. It can be anyone. It could be a nurse, a nephrologist, a cardiologist. So we need it has a lot of flexibility, but we've got to have some scope awareness here too as AI evolves in the next few years. Every action an AI takes, I think it needs to be tied to the credential, because otherwise a nurse assistant's login just can't silently trigger a physician level order. And this is some future level stuff, but A background progress can't be signing my note. And we're already hearing about these wonderful things about, hey, let them answer our refills. They also are taking our call, you know, when the patient calls in after hours. That's great. And the ease of our lifestyle is what sells a lot of this stuff, but you got to check the other side of things. There are trade-offs. And so I think scope awareness is going to be really important as we go forward. I was raised by a lawyer. My dad was the federal public defender for Mississippi, so I'm always thinking about liability. And we're not too far away from the fact, if we don't start tracing what I say and what the AI, like my ambient, I do have the AI in my notes that helps me type. So I have lots of that face-to-face care that I absolutely love. If I don't say in my note, if you can't tell from an audit report or something what Dr. Bryan said or what the AI said, I can definitely envision a lawyer asking me one day, Dr. Bryan, you didn't even see this patient, did you? You didn't even do anything. You were back there in the break room and you let the AI do everything, didn't you? So we're going to want credit for our work. It's really on us to make sure that we use these things to protect the actual work that we do, because AI is outperforming humans in a lot of ways. And so how we govern these things and how we show what we do is going to be really important. Along those lines, it is mathematically impossible for AI to be perfect. They're probabilistic by design. They predict, they do not know. And we know it's mathematically impossible for us to be perfect. We're also bound by bias, fatigue, emotion, all of the things that make us human. So the goal has never been AI versus human, but our breakthrough is when AI and humans are together. We're going to cover each other's blind spots. We bring the judgment, the ethics, and the context that the machine tries to get. But you could look at that picture that was up earlier with the blueberry muffin and the chocolate chip cookie and the dog face. There are nuanced things that make us uniquely human. And I believe the future of medicine is not man or machine winning, but we can achieve more together than either could alone. But it's going to be anchored in provenance, accountability, and respect ultimately for human oversight. The machine has to be able to fall back to the human author. And in this context, that's the physician. I think it's really important that we look at, you know, we're seeing more and more agentic AI. There are some that are already FDA cleared that can, or FDA approved. We've got to watch that. This may be our next scope of practice battle for those other policy folks in the room that are looking at where do we go from here. So our electronic health records like to say, hey, our AI is good enough, or our ambient scribes are good enough. Generally, they've got about 5 to 20% hallucination rates with the ambient scribes. Good enough may be good for a lot of fields, but it's not good enough when it comes to what we do with the sanctity of human life. And so I love it, but I spend every single day editing every single note and reviewing them. And I would not trade it because it has made my life so much better. But if you don't take the time, there's errors. There's errors in every note. And let me just say this before I end with you. And I set my timer so I wouldn't go over. Physicians, please be at the table. I wrote the policy at AMA in June of 25. Thank you, Kennedy, for rescuing me when I thought I was crazy. The EHR can be our warning. We let software engineers do it for us while we were too busy treating blood pressure and diabetes. There are enough AI tools out there that you can do like I did, and you can be the fix. You can take the jump. If you see the problem, say something, write the policy, start the company, work with someone like these great minds on the call, help shape it, start the governance committee, and be the fix, because this is the future of medicine. Thank you for having me tonight.
Thank you. Inspiring and scary all at the same time. And so I'd like to introduce our final speaker before we move to the panel. And hold on. So Dr. Sucheo, I'm sorry. I had your screen up, and of course, sorry.
I can introduce myself
I
too.
got it. I know you deserve an introduction.
Oh,
Anyway.
it's okay.
That's me being too techie. I had it on two screens, and then of course the screen went away. So Dr. Elizabeth Sorcheo is professor of medicine at Cooper Medical School at Rowan University. She's the director of medical humanities and climate health. She's the co-chair of ACPNJ's Wellness and Health Policy Committees. She's leading statewide sustainability initiatives in healthcare. She's a frequent speaker on climate, wellness, and medical education, and she's the editor for multiple peer-reviewed journals. She has taught us so much about the effect of healthcare and climate that I thought it would only be proper to include Dr. Sorcheo to review the hidden climate crisis of medical AI. So with that, Dr. Sorcheo.
Thank you so much for the kind introduction. And I have to say, it's a bit of an omen that in a tech talk, my video doesn't work. So my apologies for that. I thought I would get AI to take a stab at generating this PowerPoint. And I have to say, it did not turn out so well. There were a couple slides that I could salvage. The first one is one of them. One of the really bizarre things was that it gave an incredibly rosy outlook on the climate crisis. I almost felt like there was a little bit of psychological manipulation going on there. So we're going to go through most of these. Some of the images I preserved, but most of this, everything had to be scrapped and redone. So I will say, just in general, there is a huge environmental cost for everything that we do in healthcare. Healthcare overall produces about 8.5% of US greenhouse gas emissions, and that is before we take into account the AI environmental cost and the energy, the water, the rare mineral usage that goes into it. So we are already a very energy intensive specialty, and this is just adding to it. There are a couple numbers that I'll throw out there. I'll just say that the data is very much in its infancy. There has not been as much attention paid to the adverse environmental costs as some of the other adverse costs that Dr. Bryan so eloquently alluded to. So you can see in this one metric that there's almost a doubling of power just over the course of about 2 years, in part driven by generative AI. And it's important for us to understand that even though we're talking about cloud computing, all of these data centers live in the world. They live in our backyards. I know Delaware's right now proposing a massive data center that would essentially use up the majority of the energy in the state. So they're trying to figure out what to do down there. But there's direct implications for biodiversity, for water use, for greenhouse gases. This is from the UN Environmental Program. AI is already being used for good to look at things like charting methane leaks from oil and gas fields, mapping destructive dredging of sand. We know that from business models, it can be used to enhance efficiency, to try to make more planet-friendly choices. But of course, there are significant impacts. We'll go into these in a little bit more detail, but the e-waste that's formed, the large consumption of water very often in areas that maybe water deplete already, the reliance on critical minerals and rare elements, and again, the massive use of electricity that if it's not coming from a clean source is going to be from a fossil fuel generation. And these are just two of the UN SDGs, the Sustainable Development Goals 9 and 12, that are particularly pertinent to this discussion. So I won't belabor this. This was already gone into in great detail. So these data centers, they require a massive, staggering really amount of grist. So just making a 2-kilogram computer requires about 800 kilograms of raw materials. And many of those are rare earth elements, which may be mined in environmentally destructive ways. And the e-waste can be things like mercury and lead, which obviously we know have significant health outcomes. If we're looking at some of the other components we alluded to, the water use. So that's during construction, but also continuing through operations. And while there's been a lot of quotes about what this could look like, it's estimated that within a couple years, AI infrastructure could consume 6 times the amount of water of Denmark. And thinking about desertification and areas of the world that are already water deplete, a quarter of humanity already lacks access to clean water. So these become even more in a resource deplete environment. when you're considering the amount of energy, you'll see all kind of quotes of different numbers for this. So you can almost pick the quote that you want to use. But ChatGPT in general consumes about 10 times per query the electricity of a regular Google search. Now, of course, AI is being incorporated into regular Google searches as well. And if you look in Ireland, which is a big tech hub, they were projecting that in 2 years, the data centers could account for about a third of the overall energy usage. So this was one of the AI slides I kept here. So if you're thinking about the market growth, I mean, certainly there's going to be a lot of potential benefit. The growth projected to be about almost 40% annually over the next 5 years. It's mainly has been investigated in terms of the clinical outcomes, the feasibility, but again, a remarkable lack of information on the environmental impacts. And as you think about how quickly things develop, that quick pace, that fast turnaround can actually also lead to obsolescence of the software and the hardware, which then drives even more environmental costs as you have to think about upgrading technology. So when we think about the carbon footprint, again, a big range. It's hard to predict. Even AI has a hard time predicting exactly what that range is going to be. European Commission estimates almost a 30% increase over the next 5 years, but there is a remarkable lack of transparency. And so it makes it hard to actually calculate those numbers. The other thing that makes it hard is the multi-layered production process. I alluded to all of the materials, the raw materials that go into it. Very, very complex production process. And a lot of the initial data is focused on the initial trainings and inferences and everything that goes into the machine learning that was discussed earlier on. There has not been as much focus on the ongoing usage. And so that's another big hole in our knowledge. Now, what we do for other areas when we're considering healthcare sustainability or climate smart healthcare, we turn to life cycle analyses. And these are done by PhDs who have special expertise in how to do this. And essentially, they'll take a product like a laryngoscope and they'll look at everywhere from the extraction of raw material when you are digging up the metals from the ground to the manufacturer, to the end of life disposal. How is it disposed of? You will take all of that into a life cycle assessment. And that's what we will do for medical devices, for things like laryngoscopes. So it kind of depends how you're drawing that circle around the processes. And we haven't done that yet for AI to say, what should that circle be around the AI process so that we get the right data? There was a lot of discussion about getting the right data in so that you can get the right outputs. And very similar as we talk about environmental outputs. Some other considerations. So, so AI from Apple, Google, Microsoft, they are claiming that they may be carbon neutral in the near future, but again, lack of transparency. Some of these are from carbon credits, and the problem with using carbon credits are that, again, you don't exactly know what that means. Carbon credits could be planting trees, but if they're planting trees in a desert and not watering them, well, then you're not doing any good at all. If you are cutting down an old growth forest to build that data center and then planting trees, well, you're not doing any good either. It takes about 20 to 30 years to have a forest become an old growth forest and actually start sequestering carbon. So we have to really be careful when we're talking about carbon credits. Now, the International Energy Agency does report that if the current efficiency trends are maintained, that potentially in a best case scenario, you might be able to have flat growth. And that's if there's renewable energy sources, if there's improved cooling systems, efficient processors, proper recycling. So in a best case scenario. Now, in terms of legislation, there have been many non-binding recommendations. Almost 200 countries have recommendations about ethical use of AI. Both the EU and the US have introduced legislation to temper the environmental impact. But again, nothing is binding. There has certainly been pushback from a grassroots effort from people, the NIMBYs, not wanting it in your backyard, but we have to think from a more global perspective about this. We also have to think, though, that there may be a potential for AI to reduce greenhouse gas emissions. So if AI is good at affecting things like efficiencies, can we potentially use this to help our facility management, to decrease our air exchanges and ORs when they're not in use, to turn off lights when the offices aren't being used? So potentially there could be a benefit there. Also, in terms of things like supply chain management. Supply chain takes about 80% of a health system's carbon footprint. So there would be potential benefits to optimize supply chain and workflows. Now, I wanted to throw in two theories from more the economic world. So Jevons paradox was with coal, and the hypothesis which came to pass was that as you start to build in more efficiency, you're not going to use less, but you're going to use more of the resource. And that's for numerous reasons. But potentially, we could see there was a picture of an AI-powered self-driving car. It might make more people drive than take public transit. Or, as was alluded to, AI could generate misinformation and downplay the threats of climate and environmental degradation. One of the other things I wanted to call your attention to is the Gartner hype cycle. And many of you may already be aware of this, but there's been a lot floating around in the ether about how we're kind of at potentially the peak of inflated expectations right now. And there's a lot being written about how we might be coming upon the trough of disillusionment. They're very evocative terms that they put here. And so the goal would be that we would then temper our use, come onto the slope of enlightenment, and then have the plateau of productivity where we find where the right place is for AI, we fit it into our workflows, and we minimize the environmental damage as a result. But all of this environmental damage has the potential to have a public health impact because we're talking about greenhouse gases, we're talking about pollution through combustion of fossil fuels that leads to respiratory illness, to extreme heat, to water contamination, to all of the effects that I'm happy to go on and on about, but I won't burden you with right now. So some of the other things that we have to consider, the unpredictable outcomes. So AI could potentially not only be used, but instead of replacing one resource, it could just be layered on top of it. And so we could potentially not be getting an energy or an efficiency benefit. There's a lack of multidisciplinary research. Again, it's been unifaceted and not multifaceted at this point. There is a potential, though, to use it to help for things like when there is extreme weather events, identifying vulnerable populations, helping with disaster mitigation, potentially helping with patient pathways and streamlining that care. So maybe it could prompt us to say, well, maybe you don't need to have the CT, you can get the ultrasound. So you have a decreased energy expenditure there, or maybe do the CT instead of the MRI. So again, opportunities to decrease energy usage. We should also be thinking about this, again, not just in terms of clinical outcomes, but also cost effectiveness and sustainability. So taking that more holistic approach. From a UN environmental program perspective, there have been recommendations at the multinational country level, but we need to really, at this point, bring this all back to healthcare and to a more regional level. So I'll conclude my conversation right here. I just have one QR code just to point everyone that there are new groups that are developing to pull together that multilateral input that we need. Economists, environmental lawyers, scientists, physicians, so that we're all rowing in the same direction. And I'll stop there and turn it back. Thank you.
Thank you so much. I mean, it's just, when you think about how much there is to cover, a lot of food for thought. And so what I'd like to do with the little time that we have left, if anyone has any questions, we can do a couple things. If I was trying to screen through, Josh, if you've seen anything, I do appreciate Dr. Like for posting some resources. So that's in the chat. Does anyone have any questions that they'd like to ask? So our speakers, if you know exactly who you'd like to pose the question to, otherwise go ahead and ask the question, and then I'll let our panel decide who wants to answer. Dr. Orland?
You're on mute, Steve.
Okay, hi there. Yes. Every speaker was wonderful, giving different aspects of things. And as Kennedy, among others, know, I'm not a great computer person, so to speak. But as Dr. Bryan said, that, ever since we started using, EMRs, 15 years ago or more, that AI was even embedded in the system. Now, I remember when our large urology group first started using it, there was the option for the EMR to choose the codes that we would use for billing based on our documentation in our notes. And we all said, or a lot of us said, no, 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 because we know the doctor is responsible for the coding. And if you ever get audited and you did something wrong, it's the doctor who gets thrown in jail, not the office staff or anybody else. Well, even bringing that up to present day with AI, it sounds like what some of the speakers saying, whether it's efficiencies and that's looked at by governance, or whether it's, all the different things that the large language models can do. Eventually, though, as Dr. Bryan again brings it down to the basics in the exam room with the patient, that, I guess your environmental AI is good. Ambient AI, I think is the word, is good to speed up the documentation process. But in the end, we want it to do our coding for us or not? And so it's still the same question as 15 years ago when EMRs came in.
Okay.
Right.
So is the
It's Kennedy and Dr. Bryan maybe be the
Yeah,
ones to answer that.
Steve, you make some great points there. Regarding all of these tool uses, and yes, AI has its fundamental. AI is a lot about it is about rules, right? Rules and rules automations and who sets those rules, how those rules are, and again, EHRs are really just sort of they're complex systems, but they're based on rules. So yeah, there are a lot of these rules, and again, the evolution of medical AI, of healthcare AI. Now we're talking large language models predicated on interpreted languages and high computing power. But believe it or not, Rutgers University was a pioneer here in New Jersey in AI 30 years ago, in terms of machine learning for ophthalmology. Back in the 70s. So again, it's all about rules and the use of computers and the power you have at the time. I see, with what I see with AI, and I do worry about the environmental consequences, because all this documentation is man-made, right? All of these rules are man-made. All these rules are man-made, and it has a real impact on the wellness of patients and physicians, right? Prior authorizations are artificial. All of these things, it becomes a cat and mouse game, and who has what AI to do what with who, how to stay ahead, and not lose money or get that dollar. So yeah, it's there. Whenever there's a new technology, there is going to be a changing landscape of risk.
My answer to that is, I love it. I love innovation. I have leaned in, so I'm definitely not anti-AI, but responsible AI, and do not think that the computer is smarter than you, no matter how much they're saying that it's outperforming. And I understand that's in certain scenarios, you need to be verifying everything. So at the end of the day, go back and look at everything old school. So I let it do the skeletonizing everything, but I'm checking and I'm making, is this code right? Is this diagnosis right? Did it get the bulk of the note right? Because a lot of times it's not. But here I want to say this example. The suggested HCC codes are my big beef, because there's money tied to those, and they're pulling from other institutions things that it thinks, and it's getting savvier and savvier. And there's a lot of error baked into that. And in January with value-based care, it will say, here are 30 diagnoses. Don't you got to readdress all these. You're burned out, you're tired, and it's tempting to hit that plus sign. And here comes 30 diagnoses into your chart, right? And I'm not even worried about you. I might be worried about a lesser trained provider who only went to school online and is trying to get out of the room. And then that goes, and all the money taxpayers are paying. It's such a complex problem that a governance platform really would help us filter a lot of the nonsense out.
Well, I guess the AI also never read the CPT book.
Yeah.
Dr. Swee had a question.
All right, Dr. Swee.
So I'm sorry that I came in late because of the irony of it all is my computer froze on me just when this was beginning. So a half an hour later I couldn't get in. But
There is a Governor Murphy of this state, David.
yes, I know. So an hour, but I did hear the last hour, and so I'll watch I'll watch Kennedy's talk later, I suppose. But I just want to make sure I'm thinking forward from the MSNJ position, and where are we going with our current response to these issues? And we have a committee, right, Kennedy? You're running that committee. Why don't you tell us a little bit about the plans for that?
Well,
Again,
at this point, we do have via resolution before to have a health information technology task force and AI committee, which is currently being populated. So right now, at this point, to address some of the key issues that we talked about, then I will work with Dr. Blumenthal to recruit the appropriate subject matter experts to populate that committee and then start looking at some of these policies. And I know that Dr. Bryan, and I worked, at A24. We're going to be hitting A25, and then now hitting I-25 to finish up, and then setting this probably a new agenda collectively, probably with our delegation with the Southeast, heading into into A26.
Yep.
okay.
Right. Thank you.
Thank you.
Yeah, great area for collaboration. Anyone else with a question? It's a lot of food for thought. So hopefully what this has done is kind of created that curiosity about, okay, how can AI certainly be implemented, but what are ways that we can do it with governance, which I think is probably our take-home lesson here. And that remember that the buck still stops with the physician, and it should be to improve patient care and not endanger it.
Peter has his hand up.
Yep, I was going to say Dr. Blumenthal has a question.
Dr. Bryant brought up a thought from one of the most famous doctors in New Jersey, although not a medical doctor. I'm referring to Dr. Lawrence Peter Barra, who said that in theory, there's no difference between theory and practice. In practice, there is. So the theory of the AI may present us with some resolution, but that's when the critical thinking starts to see whether there is in fact a difference between theory and practice. Thank you.
Thank you.
Eloquently put, Dr. Blumenthal.
Yeah, thank you very much. So I'd like to give our speakers the ability to, if you just want to just kind of do a quick, if there are any last thoughts before we wrap up. Starting with Dr. Ganti.
I want to express my gratitude to all of you for coming to our talk today. To Dr. Parsa Merhaji and Vikas Khosla, who I get to work with outside at Cognome, and then to Dr. Jennifer Bryan, who I've worked with at the AMA on various issues, but most notably on AI and AI safety. And we had quite a bit of minds to convince, but they you keep it going, it going. It's that old physician grit, right?
That's
right. We've got a lot of the policy there. So I want to express my gratitude to all of you. I want to express my gratitude to the staff of the MSNJ for chasing us and getting this going, and finally to Dr. Nicole Henry Dindial to with your persistence and making sure we get this done, and every one of you, Dr. Merhaji, Vikas, Dr. Bryan, and also Dr. Churcheo. Just again, a master class today. I have not been a part of a better webinar in some time. So thank you very much.
Thank you.
And I second that. Thank you for everyone for the opportunity to present, and I learned a lot. Thank you for inviting me.
Thank you.
Same here. Same here. I just want to reiterate what Dr. Bryan was saying before. I mean, AI is probably the hottest technology in the history of this planet. There's no going back at this point. I think we'd all agree to that. So, but in healthcare, physicians can't sit on the sideline. You have to be involved in this thing. You want to be a voice that affects how this goes and how it's implemented and the governance around these things. It's critical for physicians to have a voice in that and get involved.
Wonderful.
Thank you for the opportunity.
Thank you.
Really.
Thank you, everybody. And with
Thank
that said, if you want to join or you're interested, You can reach out to MSNJ so we can get people involved who want to be on the Healthcare Technology Task Force. And also resolutions. Our next resolution deadline is, I believe, November 20th. So if you have thoughts, even if you need help polishing it, just go ahead and submit it. We want to bring everyone to the table and get those thoughts in. All right.
And I would be remiss, is my old habit as a past president is also for those of you who decide to join, consider making an extra commitment to our MEDAC, and also help us power the fight in Trenton. We do the policy and strategy panel to set policy in the MSNJ, but it's our MEDAC that helps us make sure that some of the wily coyotes in Trenton don't make AI go sideways, as they've done with other technologies in this state. So thank you.
All right. All right. Thank you, everybody. It's been a pleasure. It's been an honor to have you all, and I hope you had a great night.
Have a
Thank
great
you for
evening,
having me. I
everyone.
appreciate it.
Thanks again.
Thank
Looking
you.
forward to
Be
seeing
well,
Jen.
everyone. Stay safe.
Bye, everyone.
Bye-bye.
Good
And the
night.
slides will be available, right? So we'll
Yeah.
do that. Okay.
Thanks.
Bye-bye.
Thanks so
night.
much. Take care. Bye-bye, everybody.